And now, without further ado, I would like to introduce Dr. Sarah Lageman, as she will be presenting on cognitive changes in Parkinson's disease, what to expect and how to manage. Dr. Sarah Lageman is a board-certified clinical neuropsychologist with clinical expertise in adult neurologic disorders. She engages in clinical practice and research initiatives at Virginia Commonwealth University's Parkinson's and Movement Disorders Center. Dr. Lageman's clinical practice is focused primarily on outpatient diagnostic neuropsychological assessment of adult and geriatric populations. She has particular interests in neuropsychological function and neurorehabilitation of individuals with neurological disorders and illness, with an emphasis on Parkinson's disease and other movement-related disorders, in addition to mild cognitive impairment. Dr. Lageman's therapy focuses on adjustments to medical illness, depression, and caregiver issues. We're so glad to have you, Dr. Lageman, and please take it away.
Thank you so much, Casey. It's great to be here. And just like Casey said, if you have any questions during the talk, I'm happy to try to look at the chat and answer them so that you can keep up with the material. And we'll also have some time at the end. So that's one thing that's hard on a Zoom versus in person, but I really do like to answer as many questions as you have. So I'm going to share my screen and just give me a minute while I click on the top and get that up. So everyone can see the first slide, hopefully. And so today I'm going to share with you all about cognitive symptoms in Parkinson's disease, kind of common changes and how those changes can occur. But I really want to also focus on what you can do to manage them. There's so much you can do besides medication. So that's what we'll focus on today. As most of you probably already know, Parkinson's was initially really thought of primarily only as a motor disease with tremor, rigidity, and slowness of movements, or postural instability where you can't stand in one position as the key cardinal features. However, we've really learned that non-motor symptoms, that's what NMS stands for, significantly impact quality of life. And nearly everyone with Parkinson's has a non-motor symptom. So I listed some of the areas that they occur in. They really occur, it's a whole body illness. So you can have cognitive changes, mood changes, gastrointestinal, blood pressure, urinary changes, respiratory or sleep problems, and there's even more. That could be a whole talk in of itself. So we're going to focus really on cognitive and mood and what to do about those today. So what's interesting is even though most neurologists and people that hear of Parkinson's think of that tremor, that's the main symptom, mild declines are detectable on formal testing, what I do, neuropsychological testing, in about a quarter to a third of people, even fairly newly diagnosed. So some evidence has even been within 2 years of the initial motor changes, cognitive symptoms are there. They're very subtle though, so they're not typically what the person is actually saying they need help with right away. What kind of changes these are, we're going to talk a lot about in depth. So it's really a pattern that we call in my field frontal subcortical. And that means it's the front part of the brain right behind the forehead. On the slide, that's this pink area to the far left is the frontal lobe of the brain. You're looking at it sideways. The front part of the brain connects by a lot of connections. If you look on the slide, that deep red area is called the thalamus. And deep in those subcortical structures is where the cells are losing that dopamine that's causing the Parkinson's. And so all the connections from the deep center, that subcortical area, connect to the frontal lobe. That's the pattern that we see in Parkinson's. So those the areas of thinking that are impacted are like your general speed of thinking, just how quickly you can respond or take in information, your attention, working memory, which we used to use all the time when we remembered a phone number long enough to dial it. Now we don't even look at numbers. So it's sort of like your online memory for what's going on. Executive functions is a complicated term, but we'll talk about it. It really means like reasoning and problem solving, strategizing. We use that in much more complicated activities. And retrieval of memories. So we'll talk a lot about this. Someone with Parkinson's may have forgetfulness or memory problems, but it's quite different than other memory problems like in Alzheimer's. And we'll talk about why, but it's more retrieval of them is hard. So in everyday life, people complain they're slower to accomplish things. They get distractible. My little stick figure is to represent how you walk into a room and forget what you're doing. We all do that sometimes, but some more increase in that can happen with Parkinson's, where you just lose your train of thought and don't know what happened or what you were doing. Real difficulty multitasking or doing more than one step, forgetting names or just general things in conversations, and definitely more trouble with complex tasks. We're going to talk a lot about what to do about these things, but I have these images of files over here to kind of cue me to explain that the memory problems are different than Alzheimer's. And my theory, this is a little more theory, is that it's like the files of our memory get mixed up. So the information is still in your mind, you can't put your finger on it. And that means in the moment you're forgetful, but it's quite different than someone with Alzheimer's who cannot recall that information with cueing or any kind of time. Often people with Parkinson's tell me a few hours later it comes to them, but unfortunately that's very frustrating. But cues help. And so just like that file cabinet, we're going to talk about how partners can actually cue people to kind of get those memories back out and pull them out of the file the way you want. Doesn't work all the time, but it's definitely more possible than in someone with Alzheimer's. So I'll come back to this slide again, but I do want to talk about, there's lots of things that can affect thinking. So you can have what the Parkinson's is contributing to, but if you have mood issues, sleep problems, fatigue, pain, any kind of appetite or nutrition issues, and even medication side effects can really negatively impact cognition. In any older person, not just someone with Parkinson's, this word is really fancy, but anticholinergic means it's a class of drugs that are known to impact memory in older people. It's often in like urology medications and things like that. But you would definitely want to check with your physicians that you're not taking something that's making your thinking worse if you can avoid it. Sometimes it can't be avoided, but a lot of times it can be. So we're going to talk about the range of symptoms. And, you know, I highlighted on the slide here, minimal, mild, mild to moderate, moderate to severe, and severe. But, you know, I want to emphasize to you, the changes do not happen quickly in Parkinson's. So Parkinson's disease is something when I meet people in clinic, they often ask me, what can I expect? And I'll say, well, you know, every year when you look back, maybe at the holidays or sometime that's sort of an annual turnover in your life, you may say, oh, something's a little harder or different, but it's not something where you should ever notice a sudden change. You shouldn't one day be able to do something and the next day or month not be able to. Things that happen quickly like that could be strokes, metabolic problems, if you have an infection, different issues, but it would not be the Parkinson's that's sort of accelerating at that rate. So we're going to talk about these things, but minimal would be really just the motor symptoms. And sometimes I meet people who very early in the course of their disease maybe have, one isolated weakness, but on testing, honestly, unless I tested them, I wouldn't even know that they cognitively had Parkinson's. Some mild changes can then occur, and they may be more noticeable to the person, but not really negatively impact them. So they can still get around these issues and do things to help themselves with those problems. When things get more moderate is when I say clinically, you're likely to have regular trouble with something or need a little more help and increasing help over time. And then moderate to severe, of course, is increasing with activities of daily living. And severe, we wouldn't want you managing things on your own without help, for sure. And we'll go over some of these in more detail. But when people have very subtle changes, I like to meet people early in the course of their illness, because really the habits you set up early help you throughout all stages, and it's easier to learn them and pick them up early. So I love this image because none of us are good at this. So you don't have to have Parkinson's to not be able to do 5 things at once. We like to think we're good at multitasking, but we're really not. But very simple things that help everyone, and not just people with Parkinson's, is to clear your workspace of other tasks. Do your hardest thing at the best time of day for you. You know, if you're fresh in the morning, that would be when to do the hard task. When you pull out, I have patients who tell me this all the time, that their meds are kind of not the best at like 4 o'clock, and they pull out their checkbook. It isn't going to be a good time. I can tell you. You want to make sure you're optimizing your sleep and exercise, because those really support brain health. And definitely treat mood symptoms, any pain or sleep conditions, because those all are going to impact cognition too. So I emphasize using compensatory tools, and we'll talk about a lot of them. Sometimes people say to me, well, shouldn't I just try to use my memory and maximize use of it? Really, I think we have too many things to remember to not use tools. So if you're a person who's never used a calendar, I think it's a really good idea to get used to using one now. And we'll talk about how to use one. But pill boxes help organize medicines. Particularly those midday pills are very hard to remember. It's not a natural thing for us. We usually take pills in the morning or at night. You may need an alarm system. And using your environment to help you with cues. Like I have the image of the key holder here, but like I have to put my glasses down because I can't see them without them on. So there's a special place I put my glasses. There's a special place I put my keys, you know, and having a place that's where all your things are that you look for is helpful. So those very subtle changes may or may not really be bothersome, but as things kind of develop, mild cognitive impairment, and that's what MCI means, can develop. And we're going to talk what this is, but it develops in 17 to 30% of people at any point if you're assessing a population. And you're going to see this third is a very common number in Parkinson's. So plenty of people don't have development of this right away, but mild cognitive impairment does occur in Parkinson's. This term was initially developed in the field of Alzheimer's disease. And you can see here, the neurologists were trying to identify people before they diagnosed Alzheimer's, you know, because we can help someone the most before the disease has taken hold. And so you see on the slide, mild cognitive impairment was trying to identify a diagnosis that then led to probable Alzheimer's, which is AD, and then definite Alzheimer's. This was where it started. And Dr. Peterson is a neurologist at the Mayo Clinic who came up with the term. And it means that there's a cognitive complaint, either from the patient or a caregiver, essentially normal activities of daily living, normal general functioning, but there's an abnormal cognitive finding on testing, even if it's been corrected for age and education. And age and education corrections are important because as we age, there's some natural changes that just occur that are not any concern of Parkinson's or anything else. We all get a little slower. We all forget a little information, but it's not something that's problematic. But these people are doing fairly well. But this slide now shows you MCI has been applied to all kinds of disorders. So amnestic means memory focused. So obviously AD is the Alzheimer's, is a primary memory loss. But you also see in here vascular dementia, that's the VAD, and depression. So people with those conditions could have a primary memory problem. Depression is one that's particularly important because this is one where if with correct treatment, the person may stop meeting the criteria of MCI and actually get better. So, but MCI is a key area where we try to intervene because we think we can keep people healthier longer before there's more impairment. The non-amnestic area, that's non-memory focused, could be things like frontotemporal dementia, if you've heard that term, or Lewy body, we're going to talk about today, and vascular dementia. So it now is applied to many areas or diagnoses. I am careful though. I often put this in reports, but I will say it's due to Parkinson's. There's always a thing in medicine where research kind of goes forward and some practitioners may hear MCI and think, oh, it's early Alzheimer's. That's how it was originally developed, but it has a wider area now. So they did apply MCI to Parkinson's disease, and they looked at a multi-site study of over 13,000 people, and really found a quarter, or you could say like a third, had the MCI like we were talking about. And memory was one of the areas, but you'll also see visual, spatial, and attention and executive. And so you see it's a much more mixed pattern. If you know anything about Alzheimer's, it's very much memory and naming or language issues very early on. So quite different. This just gives you a written part of what that slide just showed. But what's important is to say non-memory issues were in 11% of the population with MCI. There were memory issues too, but you know, it's much more mixed. So, whoops, sorry. I have different buttons that do different things, but the MCI term does work in Parkinson's because as people progress with MCI over years, if we follow them for 4 or more years, many convert to what we call dementia, and we're going to explain what that term means. So it is used to identify people at risk for decline, and it's a great area to try to intervene to kind of lengthen that time of better functioning. So we kind of emphasize the areas are different than in other disorders like Alzheimer's, but attention, executive, and visual spatial are primary areas that are harder. Memory can be impacted, but we're going to talk about how it's that retrieval of memories, but the memory is still in there somewhere. We do want to try to use lots of organizational and other techniques to help us with these problems. You know, I had that image of the landing pad is sort of an area where you would put all your keys and wallet and things like that. And I'm going to talk a little bit about calendars and how to use them as well. So most calendars have the appointment section you can see on the left from 8 to 6 or so. I hope that's large enough. Some even have this part at the bottom that's a to-do list. Mine has that. But research has shown that in people with mild cognitive impairment, using an extra part that's this journaling section helps with short-term memory. This was primarily developed in Alzheimer's, but it also helps people with Parkinson's or other issues. The idea behind this is that when you decide and you look back on your day and think, what do I want to remember from today? First of all, you're using your mind to kind of process that information, but then choosing what to write down. Writing it down is a whole nother level of focus and attention. And then you also have the calendar to go back to. If you think, did I forget something? You could look at your notes and kind of review that. So there's a lot more potential for rehearsal of information. We encourage people to get used to using a calendar, to writing a lot of things down, and to look at it at least 3 times a day, you know, to make sure you don't miss appointments or lose track of things. This could be when your appointments are, but also like tracking your medicines if you have a hard time with that. The other thing that people will talk about is when you exercise. If you track your exercise, it helps motivate you to do it more. So if you make an appointment that you're going to exercise, you're much more likely to do that than if you just think you're going to exercise. So as you know, MCI progresses, that's the point I wanted to make, is these things are very subtle. It's not like one day you just can't do these things, but over time, there'll be increasing need to help with some sort of more complicated, or what we call instrumental activities of daily living. General activities of daily living are like bathing, dressing, feeding, but instrumental are like balancing your checkbook, managing your finances, paying your taxes, more complicated things. I really want to emphasize that people stay active, but we also want a safety net or some checking with them. The two areas that we emphasize are medicine management and financial management. And that's because these are two areas where small errors, like if your attention wanders, could produce big changes. So if you miss a few doses or you double up on your medicines, that could have big problems. And if you put the wrong numbers on your checks or you forget to pay bills, you can also have bigger problems. So I always tell people, sometimes people come into my clinic and say, well, I let my spouse do the meds, but I take care of everything else. And I think, well, that's the one thing maybe not to let them just do. Two pairs of eyes on these pill boxes that are huge are much better than one person managing that. But I think other tasks at home, we want people to be active. The other thing I put in here to remind myself is I see increasing scam attempts. They target older people and they are increasingly harder to differentiate if they're real. And so I've unfortunately met a number of people who've fallen victim to this. So it's very important to not agree to anything on the phone, or anybody who's reaching out to you, kind of be hesitant about proceeding with any kind of financial issue. As these symptoms can change, I think it's important, and it's hard to appreciate, but visual noise can be very hard to sift through. So I put this image of the family calendar. We all have them that have the cards, reminders of doctor appointments hanging off and things taped on, and it's tons of information. And that kind of calendar is very hard for someone with Parkinson's to find what they want and figure it out. So you want to kind of simplify some of that. That day planner I showed you was one day at a time. So there's lots of room for the day. Sometimes people still like a month view for like trips or unusual appointments, and that's fine. But looking at something that's just what today is can often be very helpful to guide a person. Some people even use, as things progress, like a whiteboard, that today is Monday and we have Dr. So-and-so at 3 p.m. or whatever. If someone's asking you over and over, that can be helpful to just cue one piece of information. And use a routine. So put these where you use them, in your kitchen or wherever's accessible. So we talked about kind of clearing your spaces, rechecking your information, taking frequent breaks helps kind of refocus your attention. So I think some of us tend to just work on something and keep working if it's hard, but actually working on it a little bit and then looking at it again will actually be better for catching errors. So there is sort of, this is a tricky time in terms of finding a balance. We want people engaged. I always say, like, your brain likes novelty, so you really need to come up with things that you engage in, but you do want to kind of have a safety net for areas that could cause you trouble. I have just a few slides in here in case people are interested. Mild cognitive impairment is a disorder that you can be diagnosed with. The DSM, which is our manual for diagnosing psychological problems, talks about mild neurocognitive disorder, and that's sort of probably a little more advanced than MCI in terms of its more modest decline. So it's more impactful. And then, and this is just if people are interested, but then it can progress to major neurocognitive disorder. And this is what we call dementia. I always like to explain the term dementia because most people think of Alzheimer's. So dementia is just a term that means that you've had cognitive change from your baseline, but also that it substantially impairs your ability to do what we call activities of daily living. So where there's maybe just a little need for some help and backup occasionally with finances, it progresses to, I have to take this over because errors are occurring. Or the other thing that I often see with people is that people take hours to do things that should be relatively shorter. So it can be quite effortful. And at that point, it's probably more stressful than healthy cognitive exercise, do the activity. Parkinson's dementia develops in about a third of people with Parkinson's. You can see rates vary, but I think it's important to note, this is typically when people are older in their years. So other medical conditions can interact with those statistics. So I think, especially when you go to support groups or interact with other people, I tell people never look at someone else's illness and say that's how it's going to be for me. Everybody's medical history is different, and sort of what you're doing to help with your symptoms can change things. But obviously, if you have other medical illnesses, those can interact too. People with Parkinson's do have a 3 to 6 times higher risk of developing dementia compared to a peer without Parkinson's, though. So this is a study that showed that approximately 80% of people with Parkinson's eventually develop dementia. I think, again, when you see this kind of literature, you also have to think of how long people live, and if they passed away of other things, possibly that they may have been relatively high functioning with Parkinson's prior to their death. So it's not a one-to-one correlation. So just like that transition from normal to mild cognitive impairment, Parkinson's dementia, I often talk in clinic about mild problems, moderate, and severe, because again, it's a transition. Mild problems, people can still drive and go to appointments. They may need a little bit more help with finances and kind of more complicated things, but they can do routine things fairly well. I do emphasize that it's good to come with them to all medical appointments. Medical appointments are a lot of information quickly, so it's just nice to have a partner for that, for any person really. And then legal documents. This is a time when you can still articulate clearly what you want to have happen, but at some point that becomes harder to do in a legal setting as the dementia worsens. So a lot of people ignore this. I always put it in my reports as kind of a reminder, I can't tell you when that day will be, but you want to be ahead of the curve, in having your affairs how you want them. So as things are more moderate, again, this is more regular need for help. There could be more confusion. People often develop visual hallucinations of things that people don't see. They could be small animals or objects or whole people. Sometimes they're not disturbing at all, and people can kind of recognize they're not real. And other times they can be disturbing. Some people at this point kind of don't want to be alone as much. They get some security from their partner. So there can be a desire to be together. But I think it's helpful to have in-home caregivers or going to adult day programs or activities that are a little more supervised, but still get a lot of interaction and engagement with people if you can. That also helps with caregiver burden in terms of having some time that the person is safe, but you can do some errands or things that you need to do. As things get more severe, people can need to be with someone 24/7, essentially. They might be able to be left alone for half an hour in a room or an hour, but you wouldn't leave them for hours on end. I do emphasize that depression still should be treated. There are some people who think, well, they don't know what's going on as much, so it doesn't matter. And that's not true at all. Depression should always be treated if it's present. And some more complicated problems can happen. They don't in everyone, but people can have more regular visual hallucinations or confusion, sometimes like obsessive tendencies and things like that. And these are things we treat, particularly with medicines, if they're bothersome, but if they're not, we may not. So, visual hallucinations, if people aren't bothered by, we wouldn't want to add another medicine unless we need to. but there are treatments for those. So I encourage you not to just feel like you have to experience them and not have any help if you need it. Was there a question? Let me look in the chat box. Oh, sorry, someone said soft. If I get a little closer, I hope you can still hear me. Yes, I'm reading these. Sorry, it's hard to read and talk at the same time, but multitasking is not a good thing for any of us. Some of the cognitive symptoms someone wrote sound like what happened to anyone under stress. Well, these are very much commonly exacerbated by depression or stress. The visual changes in Parkinson's are probably a little unique to Parkinson's compared to just other areas. The volume's better, sorry, thank you. We are going to talk about COVID because COVID has not been kind to anyone, but I think people, particularly with neurologic disorders who rely on some of these other aids, have a harder time. So let me, at home, I just want to emphasize, you know, people can stay at home and do well. Family members often ask me, how will I know if we need more help or what's going to happen? If people have tendencies to be active in the kitchen, the bathroom, fall risk, and they're up at night, those are 3 areas where it gets hard for a single person to manage helping the person all the time. So some people will never go into the kitchen and turn on the stove, which is great. But if they do, then you need to kind of be proactive, maybe take off the knobs of the stove or do things so that they can't leave things on if they're not supervised. So when people are up at night, that's something we really try to correct because that gets very hard for a caregiver to deal with because you never get sleep. So that's hard. In-home safety evaluations can be very helpful to kind of augment at home what is a safety concern. And you'll see here night lights, grab bars, shower chairs. I didn't put on here, but I should have. There's little portable urinals that can be at the bedside so that you don't have to get out of bed and go all the way to the bathroom if that's a far away place in your house. That can be very good to do because that nighttime fall risk is a lot higher just because you're a little disoriented and it's dark and all those things. So I just want to go over some of these things a little quicker, but there's really 3 kind of clinical phenotypes of Parkinson's. And, you know, one is that you get diagnosed with Parkinson's. The younger onset, you know, it says less than 50 years, but I would say it could be down to, 70 years, it could be down to 50. It's not that this is a set in stone number, but people have the symptoms, they gradually develop over time, but they may have 10 or 15 years of the symptoms before a lot of changes are occurring. Within Parkinson's disease, tremor predominant is a kind of more unique area where a lot of progression does not occur. It sort of just, it seems like the tremor is the only issue, but then there's rigidity symptoms, a more mixed presentation, or more that instability and falling a lot presentation. So Parkinson's disease dementia is where someone usually is diagnosed with Parkinson's disease, but relatively quicker kind of develops more severe symptoms in so many years having been diagnosed with PD. And this is for people who are older at diagnosis typically. And then you've also maybe heard of Lewy body dementia. And this is a related disorder, but it's much more, they have Parkinsonian features, but much more features of hallucinations and more psychological changes. I put an image of Robin Williams since we learned more about that disorder when he was diagnosed with that after he ended his life. So there is a kind of debate in the literature about how do you differentiate Lewy body from Parkinson's disease dementia. If you're interested in that, it's sort of a 1-year rule. So dementia with Lewy body comes on the Parkinsonism and the cognitive changes in a really tight window of about a year. Usually someone with Parkinson's has had tremor and motor symptoms for years and then gradually develops cognitive changes. So when they're really tight in time, that's more concerning for Lewy body. Let me just take a moment there. And does anybody have any other questions at this point? Because I'm going to kind of shift gears for the last part of this. And I want to kind of emphasize, we've gone over a lot of like, what are the changes and what can happen, but really what you can do. So I want people to leave feeling like there's actually what you do every day has a tremendous impact on how you're going to feel and function. So I put this slide in here to ask, like, what if you could act like you had a healthy brain, but you had some atrophy, and you can see this brain is smaller and has bigger holes and a lot of changes to it. So let's see. We know this is possible because people were found that had passed away and donated their brains to science, that they had actually Alzheimer's disease pathology, but they were functioning normally. And people wondered, how is that even possible? So we know that people who have high engagement in activities, and we're going to talk about these, have less likelihood of developing dementia in their lives. And so they engage in intellectual, physical, and social activities. One idea of this is that if we are high in these activities or have reserve, like with our education and reading level and different things, we have more room to kind of lose skills before we actually have an impairment level. Some of those things are modifiable, but some are not. So we definitely want to look at what we can do in our daily lives. So I was alluding to this. COVID has not been kind because we are so isolated, and social interactions, talking to others, uses a lot of cognitive skills, and that's very important. We also are going to talk about exercise and intellectual things like playing cards or games or doing things that are novel for your brain. Lifestyle choices are key because if you're sitting and doing nothing, your symptoms are going to be more debilitating compared to if you're doing more activities and things like that. So I put in here a lot of symbols of just choices we have to make about our food, what we drink, who we interact with. Of course, with COVID, we've had to be very careful about that. But I hope as people get vaccinated, meeting outside, at least when the weather gets better, is more safe. But playing card games, you could see pets on here, even calls are better than nothing in terms of social interactions right now. I do like to encourage people to keep their activity levels. So some people with Parkinson's with the visual changes have trouble reading. And sometimes I put the symbol of books on tape can be helpful. Playing games, journaling, things like that can be good things to do. So if you remember, we talked about all these symptoms can negatively impact life. And I just want to go through these briefly, but people do have a higher risk of depression because of the loss of dopamine in Parkinson's. And anxiety is also another issue, particularly about the medicines wearing off or having good and bad days and not being able to predict what you can do. There can be issues with initiation, can be very difficult, as well as more serious changes with more ruminations or obsessive compulsive behaviors. So about a third of people can develop depression, and 40 to 60% can have anxiety. When these are present, it's really important to get treatment for them. And a lot of behavioral strategies will help, but medications can also help with depression. I don't encourage people to overuse medicines in anxiety because you have to learn how behaviorally to manage your anxiety. Otherwise, you just need medicine all the time because your anxiety will keep growing. So that's something working with a therapist can be very helpful for. But you'll see these in the handouts. People can tend to isolate and let go of activities. I see that a lot. And those are not good things for your mood or your brain health. So it's important to kind of make choices to challenge those tendencies. The unpredictable nature of Parkinson's can really make it hard to commit to activities, and that is a challenge. So I just wanted to, we're getting close to the time for the Q&A, but I just wanted to briefly go over activities that your brain likes. And I would be remiss if I did not tell you about the important role of exercise. Lots of studies have shown that increased exercise improves, the attention, mental flexibility, and things like that. So they looked at people doing things about 3 times a week and improved executive functions and memory. You'll notice these things were about aerobic activity. And that's what I kind of want to emphasize to you. If you're doing stretching is great, but for cognitive health, you really need to do activities where you're getting a little out of breath. You want to feel like your heart is pumping and you're working it. Do you know what I mean? So they find combined aerobic exercise with strength training did better than if you're just doing aerobic. And I put the Rock Steady Boxing logo in here to remind me, there's lots of programs now to kind of help people with Parkinson's be more active in those ways, and they get your heart pumping a bit more. Dancing is another program that's for Parkinson's, that the music can actually help with some of the movement problems as well. So effort is your key. So you need to be feeling like you're a little out of breath for that to be working good for you. I think classes are particularly helpful if you have problems with initiating activity or making sure you do it. Also, using that calendar can help. And there's a lot of other tools that can help people be active. So if balance is an issue, a stationary bike can be very good. I think consulting with a physical therapist could be good to talk about what kind of rolling walkers are helpful or necessary, or like trekking poles for balance. There are all kinds of things people use to be more active. We ourselves here at our clinic did a mindfulness-based program. So with some relaxation and mindfulness training. And we did it for 8 weeks, and people improved their depression, but also improved mental flexibility. And people with Parkinson's had better quality of life with their thinking and emotional health. A simple writing did, people journaled for times over a 2-week period. And we found people wrote all about things that are common to all of us, but people had improved learning and memory skills and reduced anxiety and better depression and mental flexibility. So you can see that there's a lot of techniques that can help address these things rather than just taking medicines for them. So it's really good to try new things. I encourage people to try some creative things like music or drawing or painting to just kind of accept it doesn't have to be something you're necessarily even good at, but to enjoy that creative process and really focus on, your needs may change over time or your interests, but not to just let go of things, but to seek out new things that you like to do and engage in. And hopefully, if COVID can be better managed, we'll have a little more freedom to do those things together, but be careful with that. So I wanted the take-home message today to be that you can really improve your thinking skills with a lot of what you do every day, and that they can reduce your functional impact of your symptoms. And that's really important. Some people take the medicine from a neurologist and then do nothing different. And if you're not exercising, you're missing on a huge dose that could help your Parkinson's. And these other techniques I talked about can also help you with a lot of the other memory changes, but also mood changes as well. So I always encourage people, when you get my handouts, to think about what kinds of things you feel like you've let go of, what you'd like to target, and kind of make a plan. But so I want to be sure we have time for questions, and it has been hard for me to multitask, as I said, with the chat. So I'm going to start looking at that and see if there's any questions. But thank you for your attention and interest. Let me see. There we go. Let me read more of the chat questions. So I may not be doing them in order, but the visual spatial deficits, Carol wrote, bumping into door frames and turning corners. It can be those subtle things. On testing, I tested, they have to judge angles and match them. And they have a real hard time doing that kind of problem. So it's not like you don't see something that's right there, but it's judging depth and angles. And so that the turning or shifts in the environment are probably the hardest thing to navigate. So yes, that is what I am impacting. Claudia, you're right about the writing can get smaller, and because of the letters getting smaller. The journaling program we did, we had trouble with that. We had some people do it oral dictation, but there is some thought that writing out your thoughts is part of the catharsis to that. So I think it's good to practice the writing, and you can work with an occupational therapist if there's larger pens or pens that have more balance, to maybe help with that. But it's probably something, if someone has a really hard time writing, they probably can only do it for short periods of time, because it does get more laborsome the longer they do. So let me hit this. I'm back on here. Let me go back and see if I missed any. So one person asked if PDD was a type of Lewy body. They're both dementias. So I think of dementia as the overarching term, but PDD would be separate than Lewy body. And they would be if you put them in a list, you could have Parkinson's disease dementia, Lewy body, or Alzheimer's, or cortical basal, or other types of dementia. So they're all types of dementia, but they're not under one another, if that makes sense. Does that help Anne's question? Yeah, Claudia asked a question. Research shows, her question was about different percentages of dementia. When people study populations, if you're not comparing the same thing directly, you often get different estimates of things. So you'd have to look at each of those individual papers to sort that out. I think the thing I wanted to emphasize is generally the numbers of about a third of people have MCI. If you just look at a population, exist. Generally, if you look at a population, about a third will meet criteria for dementia. That's not to answer the question of like one person's incident risk throughout their life. And that is more that statistic of 3 to 6 times higher than someone without Parkinson's. So they are different statistics that we're talking about. I hope that clarifies that a little bit more. Yeah, I think I got back to the rest. Anybody else have any questions or comments? I know it's hard in this format, but if you want to ask anything else, feel free.
Yes, we'd like to, I wrote in the chat box, but I'm not good at that, so it probably didn't register.
That's okay.
Do you want to ask him?
Yes, I'd like to know your opinion of these memory pills. I see advertised Prevagen, and there's 3 others too. It's how if I have real memory problems, so I wonder.
Yeah, I can't speak to any one memory medicine particularly, but what I'll tell you is what I've read about the statistics on the memory medicines. This is a question that I think is good for an individual to consider with their particular neurologist. The initial memory enhancing medications, they're Aricept, and then Namenda was more for moderate stage dementia. Aricept was more for mild, and Exelon's another one. You know, when they did those studies, if they had thousands of people, they showed changes on what's called the mini mental state exam, which is a very short screener. It's hard to take from that data. Does that mean in your functional life, do you remember something from yesterday? You know what I mean?
Yeah.
So I, as a neuropsychologist, I was not overwhelmed with the improvement on the test they did. It was a viewpoint difference that if I tested you every day, I think if you slept differently, I could probably remove that much. Some people, though, I will tell you from clinic, have gone on some of those and feel like they're helpful. It's impossible to tell what you would have been like off of them. So a fair amount of it could be placebo effect, but placebo effect does exist. The medicines probably help some people, but I'm not sure it's as robust as we would like to think. You know what I mean? So I would tell you to talk with your physician about it. You certainly could try a trial. The way they work, though, is that your memory wouldn't necessarily get better, it just wouldn't get worse. And so you don't know if your memory would have gotten worse in that time of 6 months or not, but some people go on them and feel like they can notice a change. So it could be worth trying. I would say to you, I would definitely also try these aids we're talking about, because they'll kind of more support your memory too, and we know they work. Whereas the medicines can be more variable.
Is there any research that's been done on the over-the-counter medications? I don't even know if it's supposed to be called a medication, Prevagen, for instance, whether that is as good as the ones that have to be prescribed, or what? Do you know anything about that?
I can't answer that question.
Okay.
I don't know, as medicines are not under label, then they become sort of over the counter available over time, as well. There's also, just to caution you, a ton of supplements and things like that people research. Unfortunately, they're not regulated by the FDA, so it's hard to sort out if people are taking the same type of medicine and how helpful they are. I just definitely emphasize to go over those with your neurologist, because they can have side effects to other medicines you're taking as well. So it's important to let them know about that.
Okay, thank you.
What was Polly's question?
Oh, that's the male person.
Is any evidence to suggest that deep brain stimulation has a negative effect on cognition, or any kind of future damage to the cognition?
Uh-huh. The last time I did research in that, she asked if deep brain stimulation impacted cognition. The studies that looked at that when DBS was more just coming out really only consistently showed changes in verbal fluency. It's a test where we ask you to come up with as many words you can think of in a minute to certain criteria. It's not clear if people being slower on that really means in your daily life, are you slower to speak? Maybe, maybe not. Testing is always, kind of in the formal testing environment, and it may or may not translate to a everyday experience. That's the one, though, that was seen on lots of the tests. It did not have a consistent effect on other areas of thinking. So.
I have you on. Wait a minute.
Yeah, I know it's hard to unmute and mute and all that.
I have something I'd like to share. Can you hear me?
Mhm.
Okay. A recent book by the one of the co-founder of the Lewy Body Dementia Association, and there's Lewy Body Disorder organizations. They say that the The new way of looking at it is that the correct names are Lewy body dementia, which describes both dementia with Lewy bodies and Parkinson's disease with dementia. Then there's dementia with Lewy bodies that most of us, that has been known for a while. Second most common dementia nobody's heard of, and Parkinson's disease dementia. However it's classified, I found discovering the symptoms of Lewy body dementia, and which explains so many of the things that were occurring in my husband that just Parkinson's by itself hadn't explained.
And what was the resource that you were talking about? I'll look at that.
The title of the book is by a couple called Whitworth, Whitwrth, and there are, I think, a couple of organizations.
Well, and I'm going to tell you, the Lewy Body Foundation, I didn't put that in my slides, but has a great handout. If you Google Understanding Behavioral Changes is the title of it. And it's by an old mentor of mine from the Mayo Clinic. And it has a lot of strategies about helping someone with dementia that was put under the Lewy Body Association, but really they're helpful for any person with dementia. So the big thing to understand about Lewy body versus PDD is Lewy body has a lot more progression quickly. So in a year or two, things would change very quickly. And the visual hallucinations and psychological changes are much more prominent in that condition. And I did want to get back to Christine. I don't have data on DBS changing the probability of Parkinson's disease dementia. I will tell you at our DBS clinic, if you have dementia, you are excluded from DBS. We've found that people with dementia don't benefit as much from the surgery, and actually it can cause some problems to where it's turned off. So there's a lot of resource put into that, and then it's not used or helpful. So the timing of when to get DBS is a big thing to look at, but you would not want to wait too long. Most people don't have the interest in getting it when things are well managed with medicines, but if things progress cognitively, there's a point where it's not safe to do that anymore. And Judy did write here, if you didn't see that, the Big and Loud programs are great resources that help you articulate louder, but also write bigger and do bigger movements with walking if you tend to drag a foot or a leg. The programs do great. What the trick is, which is a lot of what we talked about in my handouts, is keeping up with it when you go home. So, the hard part is those programs you generally do 4 to 5 days a week. And when you're really intensely doing it, you get great results. But then when you go home, if you don't have that follow-up, you've got to keep working at that. There's another thing we talked about, dance, but singing can be very helpful for people with Parkinson's to get that vocal force. So that's probably not going to happen right away with COVID, but in the future, hopefully. So.
Actually, we have a virtual singing group that's going on right now.
Yeah, that's a good way to do it.
All are welcome to attend.
That's not the thing to do in person right now. Yeah. If anyone has other questions, feel free to email me. And as I said, I'll share the handouts with Casey and she'll send them out. I know it was a lot of information, but that way you'll have it written down. And I appreciate everyone's interest and attention. Any other questions?
Holly, do you have a question? I see your hand is up.
No, I didn't know how to.
Okay. I'll take care of that. Dr. Lageman, thank you so much for your time and expertise. And I will send that follow-up email to all of you with this recording as well as the handouts. And the last slide includes Dr. Lageman's contact information. Also, I would like to thank Acadia Pharmaceuticals for being a sponsor of today's webinar. So I hope everyone learned some new information and has a wonderful afternoon. And lastly, if you can please go to the chat box one more time and click on the Survey Monkey and please complete that. We all would appreciate it very much. I'll stay on for a few minutes so you can access that. Thank you so much, Dr. Lageman. Thank you for coming today, everyone.
Thank you. What was the link?
The link, I stopped the recording. I will send that link again in the chat box. Here we go. One more time.
Ah, here it is. Thank you.
There it is. You're welcome.